So, as we just learned, our talk today is on neurobehavioral approaches in Angelman syndrome, Part 1. What we hope you will learn about today is how we've organized our talk. We've organized it around the Health Watch table for individuals with Angelman syndrome. We have some copies available, but they're also available to be downloaded from a website. We've also organized our talk around the online behavior modules. And we want people to learn how these resources can be used to help individuals with Angelman syndrome receive appropriate care and support to maximize their physical, behavioral, and mental health. We will also include examples from our Angelman syndrome clinic in Ottawa, including some case examples. So a little bit about us. My name is Jane Summers, and I'm a psychologist from the Centre for Addiction and Mental Health in Toronto. And my colleague here is Dr. Erick, who's a neurologist from Children's Hospital of Eastern Ontario in Ottawa. We have a mutual interest in seeing people with Angelman syndrome that we discovered when we were at a conference together in Chicago. And because he deals with neurology and I deal with behavior, we decided this was a neurobehavioral approach that we take. The aims of our clinic are to improve physical and emotional health of people with Angelman syndrome and reduce the occurrence of challenging behavior, and we want to enable the person to reach their full potential and maximize their quality of life. So one of the things we're organizing our talk around is the Angelman syndrome Health Watch table. I don't know if any of you are familiar with it. This was a table that was published in 2015 by a group of people at a Surrey Place Centre in Toronto. There's a URL at the bottom, I don't have a pointer, of the page, and you can actually Google the word Surrey Place Centre and Angelman syndrome Health Watch table, and you can actually download a PDF version of it. So it was developed, it's part of a series. There's a series on autism, Down syndrome, Williams, and so on. And the purpose is to provide anticipatory guidance for health and mental health concerns and help monitor mental health and health needs across all ages and stages. It reviews physical and behavioral mental health issues and provides recommendations or guidance for how to manage them. It covers a number of areas. It covers genetics, neurology, am I going to pronounce this correctly? Musculoskeletal areas, head, eyes, ears, nose, throat, gastrointestinal, dental, endocrine and sexuality, and mental health behavioral. We've added a few more categories of our own that we'll speak about this afternoon. And we're hoping that a number of you have actually gone to the online behavior modules. These were developed to give guidance to families and caregivers about how to manage challenging behavior. And it's very simple. You go to the website that's indicated at the bottom of the page, you set up an account, and you're ready to go. And just to note, this online behavior module was funded by the Angelman Syndrome Foundation and the Canadian Angelman Syndrome Society. We're also going to use case examples from the new clinic we started in Ottawa last year. So we started seeing patients last April in 2016, wanting to build upon the success of the clinics that are being offered in the U.S. and offering services closer to home for Canadians. We also wanted to see if we could interest other medical professionals and allied health professionals in Canada by providing access to individuals with AS and providing training opportunities for them. And we're interested in developing our own line of research, experience, and knowledge base. So a little bit about our clinic. The information we have today for you to see is gathered from semi-clinical structured interviews and chart extraction. So in the 4 clinics over a 1-year period, we saw 21 children, 11 of whom are female. Mean age was about 9 years, ranging in age from 2.5 to 20. And in terms of genetic subtypes, 67% deletion positive, 14% gene mutation, and 10 each for UPD and imprinting defect. I do the behavioral part of the assessment, and I obtain information about the history, service history of the individual, information about behavioral mental health issues, safety concerns, presence of challenging behavior and related factors, and get information about what sort of information parents are looking for. And now I'm going to turn things over to Dr. Sell.
Thank you, Jane. Okay, so apologies in advance if I go a little bit fast, just so I want to be conscious that I have left enough time for your questions and for discussion. So the neurological part was born through a group of families that were very eager to have a little bit of a closer relationship with the neurology department at CHIO, and it worked out very successful. We focus, of course, on epileptic seizures, but also on other aspects of neurological function. And I have to say that for me, it has been a very pleasant learning curve, because as you may have experienced in different ways, one thing is to know about something, and another thing is to really get to know someone. So that happens in many aspects, even as a parent. You know from way before you have your own family what it's like to be around children and what it's like to raise children, but you really only know when you are inside the role. So from our perspective, seizure control, of course, is a main pillar. We also see gastrointestinal issues, including motility. We try to involve other groups that specialize in other services, such as gastrointestinal, orthopedic. We try to participate in meetings like this one to try to learn about new therapies and experimental things in the horizon. Of course, we try to do the clinic patient-oriented, so we do try to collect some information and try to learn from the families, but at the end, the clinic was born, I would say proudly, I can say that it was really born around patient care. So you probably will hear and have heard about genetics a lot, so I'm just going to say that I'll try to illustrate more with short anecdotes that hopefully make a case as to why it is important, and we keep discussing these aspects. So yes, not all patients who fulfill clinical criteria for Angelman syndrome have been found to have either a deletion or a mutation or uniparental disomy. I look after a patient for about 2 years before I was able to prove a mutation, and I go back, and this was before the clinic, so when he was one of many other patients in a general neurology clinic, and in my notes I would always read, strange, the methylation test is normal, but it looks like it still fits well with Angelman syndrome. So all of this to say, once again, that it is worth to keep in mind the genetics, not only from a diagnostic point of view, but also from a counseling point of view. As you may know, there are some mutations, some circumstances mutations where there can be more than one sibling with Angelman syndrome in the same family, so genetic counseling is appropriate. Purely from a neurological point of view, yeah, about 90%, and I'll show you our data in the clinic, but about 90% of children will have at some point in their life epileptic seizures. They tend to present around the age of 3, although they can present before or after. There's different seizure types. Difficulty with a broad-based gait, which we call ataxia, and tremors, shakiness, jitteriness of the hands, and the interesting part is that there are many medications that control seizures, but there are some that seem to control more than seizures. What we call the older anticonvulsant medications, they have been linked more so with bone health problems like osteoporosis and osteopenia. The newer ones appear to be a little bit better. Let's see if this video runs. Mrs. M here had seizures, some of which were staring spells, some were more shaking, convulsing, and I got this video sent. Let's see if it hopefully will run. Oh, maybe not. Let me see if it's gonna. Okay. So if you look at, if you pay attention to her face, that cute little face says a lot. And I bring this video because this you can see the difference from the very first 3 seconds, and maybe I'll play it again. The first 3 seconds, she seems to be drowsy, she seems to be groggy, and this is the kind of behavior that you can expect after a long seizure, which is what had happened. Seizure, a lot of medication, but it can also look very similar to what we call non-convulsive status. So let me just show you the first 5 seconds again. So look at her eyes, if it works. Maybe not. Okay. Well, if you look at this face as it is right now, you can tell that the eyelids are droopy, that there is not the same level of alertness as with the previous part of or the latest part of the video. And what we do when this happens on and off or continuously for many hours, sometimes can be days, is an electroencephalogram. That is a test that has a lot of limitations. So EEG is a test that cannot tell you many things, but it can tell you if you are in an status epilepticus that doesn't present with convulsive seizures. So on this first part here, you can see this ongoing rhythmic activity. This is the brain having kind of like shouting, synchronized voices every so often, and this prevents you from being alert enough. So you wouldn't be able to learn. You wouldn't be able to communicate the same way. You probably wouldn't be able to have the same reflexes. You wouldn't be able to navigate in a space the usual way. Some people call it to be like in a zombie state. And it's tricky because sometimes you may be able to chew, you may be able to have your eyes a little open, you may be able to be led by the hand from one room to the other. So not for everyone, especially if you're not familiar, you will be able to acknowledge that this is a form of status epilepticus that needs to be treated. As far as we know, there is no permanent brain damage, so it's not like a stroke or something that will leave permanent deficits on the brain. But as you can imagine, it's not good to have it on and off, and as it can last even days, it will prevent from your regular daily activities. It can also, there are some theories that if left untreated long enough, it can kindle or it can facilitate other brain circuits to seize better and better. So the recommendations is EEG is definitely a good tool. It helps us with sometimes even diagnosis. MRI we don't do routinely, although there are circumstances where it has been done beforehand as part of the workup for developmental delay, not yet diagnosed. There are some changes on MRI, but I won't go into much detail on that. And being conscious about anticonvulsants having different side effects. They all have their own side effects. I'll show you this little sort of street light approach that I have. That I learned from Ron Tibert, which is that all of these anticonvulsants you see there in all boxes, they all probably work for seizure types, and they can all be quite effective. The ones on the green box are the ones that have proven to be not only effective, but also better tolerated and have less side effects. I myself, in the clinic, have had very good experience with the first three on the green box, and part of it has to do even with the country you live in. So, for example, in Canada, we have been using clobazam since the early 1990s. So we have like close to 30 years of experience with clobazam. And we have found that ethosuximide in particularly, even though it is meant to treat absence seizures, it has worked really well for drop attacks. So for the sudden, no warning type of drop. Valproic acid is a medication that I use a lot in general in the neurology clinic. After sharing information with Dr. Tibert and sharing experience, I learned from him that maybe, although it's a great medication to control seizures, may not be as good in terms of side effects. So I've been trying to use it less, I understand because I've had the experience that it really works, so it can be a very effective and powerful drug, and some children tolerate better than others. So it is hard for me to stand here and give you a recipe as to how things are done, because there are many, many variables that have to be controlled. I had a family once tell me that they were in a blog and they said like, oh, I said in a blog how happy I was that we were taking off valproic acid because this and this had improved. And then there was somewhere in the other side of the blog a parent that was very unhappy because valproic acid had done tremendous benefits for them. So they were like, how dare you speak negatively of valproic acid? It's a great drug. So I think you have to take this as like everything else in life, case by case. We are all individuals. But just to illustrate our point with, this is what I saw with our same patient, Mrs. M, with her gait and valproic acid. So let's see if the videos will print. I may have to go from the source. Let me see if I can just quickly go from the source. If not, whoops. Actually, I might not be able to. Let's see. Yeah, I don't think, unfortunately, I don't think the video is playing. It was a very nice video because you could see how her gait had transitioned from before and after. Let's see if I can look for the downloads. Sorry. Let's see. No. Oops. Okay. Well, so what had happened is that with valproic acid, she was seizure-free. With now I'm trying to get it back to presentation, but okay. But with a transitioning, oh, it actually froze. Oops. What's that?
She might be able to help you play the video.
Oh, sure. Yeah, absolutely. I'll take it. I'm actually even...
Into the slideshow mode, it might play if you go like this, and then let's from the current slide.
It's kind of like frozen, eh? Oh, there you go.
Then you.
Oh, don't. Don't go too far. So you can see how difficult gait is. Eh? It's so she's working with her physiotherapist of all her life, who has done an amazing work. She works with her every day, and even then it was very difficult to walk unsupported for very short distances. Even it was difficult even to stay standing. Okay, let's see. I will. Now. This is, when you look at this video, you can see that there's an objective change in the speed, in the duration of her gait, in her balance. Parents are still very careful, but the change was quite objective. So it was the opinion of like the parents, myself, the physiotherapist that knew her from a very long time. And it wasn't only in open fields like this, but it was also at the mall. So at the mall, you could see how she had managed to walk unsupported for much longer duration and very steady. So you may ask, okay, how long did it take for this change to happen? And in her particular case, again, this was something that we achieved within less than 3 weeks. So it was from the time that we started to wean her off valproic acid to the time that she was off valproic acid, there had been a significant improvement. I just, again, to emphasize the point that everybody is different, and I have patients that have walked very well, and when we wean them off valproic acid, they didn't see such a dramatic effect, but the consensus has been so far that it has helped somewhat. When you transition from valproic acid to something else, you may actually have to deal with seizures coming back, because again, it's a very powerful, effective medication for many, if not almost all seizure types. So it does take some work to go back and achieve the same seizure control. So in our experience, seizures have happened in around 90%, like in the literature. And when we see patients hospitalized, this has been always in emergency. So we rarely at CHIO at least have needed to admit a patient for seizures only. We have had so far a very positive experience. I don't know what is out of our 40, almost 40 patients, or give or take 30, yeah, 30 to 40 patients. So far, I don't know what is a status, like convulsive status epilepticus. So we're pleased with that part. I'm going to move a little bit faster now into the musculoskeletal. Children are prone to hypotonia or decreased tone in the axial muscles to overwork some joints, especially the ones that have to bear with more gravity. So you have access to orthotics, physiotherapy, and the idea is that, for example, here in the ankle, as your tendons start to stretch, if they eventually pop out of the groove or the socket where they're supposed to attach, you can end with a deformity. And if that deformity is not reversed, even with exercising, the joint may freeze. And if the joint freezes in that posture, then you may need orthopedic surgery or at least Botox casting. So it is important to keep an eye on this, as it is important to keep an eye on the spine. So scoliosis or curves in the spine are more prone, especially if we don't sit properly for anybody, or we spend a lot of time just sitting. So if you spend a lot of time, let's say, sitting in the stroller or in a chair with the decreased tone, we normally don't have to think about keeping a posture. But when your tone is decreased, especially in the core muscles, then that kind of loosening of the strength that supports the spine may induce a curve. So from a musculoskeletal point of view, about more than 60% of the patients we saw in the clinic could walk independently, and this is a term that varies, right? So it can be like the video that I show you. It can also be with a bit less support, for sure. And very active, so swimming, walking, some dancing, playing group games. Orthotics very often used in more than 60%, and fortunately not a big prevalence of scoliosis. About 5% had at some point used Botox, usually with casting. Again, just to raise awareness that when, just like astronauts, if your gravity center is not as demanded, your bone health may be affected over time, so your bones may become a little bit more brittle. If you add to that the anticonvulsants, especially the older ones, then the minerals in your bone are not as dense, so you're more prone to recurrent fractures that may not take a severe trauma, can be just from overuse or from a minor fall. So there are some centers where they will do routine bone density. In other places, it depends on this constellation of factors, from therapy to history of pathological fractures. Medications that we not necessarily use ourselves, but that our patients that have come to the clinic are using, include all of these long lists. So you'll see that a lot of there are nutraceuticals that are used to facilitate sleep, like melatonin. Some are to help with constipation, like coconut oil, probiotics. Some are in hope to help with behavior, cognition, such as omega-3. We've had some families that out of, let's say, a formal scientific experiment had done their own minocycline experience. Carnitine is to kind of like boost the mitochondrial function, and you can see that a lot of medications have been used at some point also to treat behavior. I have to say, and Jane will definitely talk more on this, but it is not our first go-to, obviously. We try to exhaust behavioral therapies and ways to redirect behavior, as we know that these medications sometimes need to be used, sometimes can be effective, but we go case by case with caution. Gastrointestinal symptoms are frequent. Reflux, constipation. So if there is concern with not gaining weight, especially in early life, or overweight later on, it's good to have maybe a dietitian involved. We have that benefit. I can consult the dietitian and they can get involved. We tend to use PEG 33550. We find that one is effective, but of course, increasing fluid, cannot stress enough, fluid and fiber intake helps. So increasing activity levels, it's also known that it helps with better motility. Our experience, there are many different behaviors that happen around the time of eating and feeding, and it includes having to spend more time or trying to be careful not chewing too fast, because it can correlate with some more coughing or gagging. Gagging has been quite prevalent. Disruptive behaviors at the moment of eating. We haven't had severe cases of aspiration pneumonia or anything as such, and reflux, of course. We have a couple of patients that have therapeutic diets, like the low glycemic index diet, or they have reduced gluten, and we have a small number of patients that use a G-tube for feeding. This is an example. This young boy, I'll call John. He has a very good balance. He has a very good motor function. As you can see there, he lives in a small farm, and his parents raise like these small ponies, and he has a great space, open field to run, and so he has a good strength, a good musculoskeletal function. But unfortunately, since very early in his life, he hasn't been able to tolerate almost anything. So for some reason that we have not yet been able to figure out, he has these very severe reactions with a lot of pain. We suspect a lot of discomfort when he tries to eat anything but a very specific pre-digested formula. So in order to keep him well hydrated and in order to be able to give him some form of calorie intake and nutrition, he uses this pre-digested formula that goes through gastrostomy tube. And his quality of life overall is quite good. But yeah, if anybody has heard or experienced something as such, I would be interested to talk maybe at the end, because I would say that he's definitely an outlier in our clinic. I have discussed his case with Dr. Tibert, and yeah, it's still a bit out of usual. So toileting, we can expect daytime bladder incontinence, which is common, especially in young children, and especially in those that are still dealing with epileptic seizures or medication to treat them. It can predispose if there is also retention to urinary tract infections. So training and having a routine is probably one of the best advices. Constipation is one of the cases or one of the reasons for incontinence. And vice versa. So sometimes urinary tract infections or bladder malfunction can affect constipation. So in order to reduce accidents, again, being able to form this routine, exercising, following the recommendations to have a healthier habit. So taking the time for this is important because you will show you a case at the end. If you let this become something very severe and chronic, you could end with what is called a megacolon, which is a very significant distension of the very end of the colon, and it kind of like trains itself to become a distended bag, if you wish to call it, and then it is more difficult to deal with it. Sometimes it may require to do like a disimpaction, like actually disimpacting the feces, which is traumatizing. Yeah. So in our group, almost 40% have been urine trained, and about 1 in 4 bowel trained. Accidents were common, but mostly during the day or related with seizures. And the families were at least 2/3 working actively in learning this. This is the case of Lindsay. Should I go ahead and talk about it?
Right.
Let
Okay.
you.
We just wanted to present a case to you that could illustrate some of the points we're trying to make. So Lindsay's a 20-year-old female with deletion-positive Angelman syndrome. She has a seizure disorder and takes 4 anticonvulsants daily. She's reflux, and her mother says she doesn't like to drink liquids, so it's a real struggle to get her to drink water, but she does like chocolate milk. So work with that, I guess. She's quite mobile and walks independently, and she's time-trained and will stay dry between trips to the bathroom. So Lindsay is very high-functioning, in my opinion. She's quite independent, quite able to do a lot for herself, and is in a good school placement, which is unfortunately ending in a few months' time. But she has a history of constipation, and in the last year she was taken to the emergency department 3 times in relation to inability to pass stool. And I think the mother said at one point she hadn't had a bowel movement for 9 days. So this is getting to be quite severe. The mother was very concerned, and so was the school. So she took her to the hospital, and they did some x-rays and investigations and found a very large mass in her abdomen. So they had to give her laxatives and clean her out, and her mother has to manually disimpact her at times. But her mother noticed that signs of constipation in Lindsay are her abdomen becomes very bloated. She doesn't want to eat. She's very uncomfortable, doesn't want to eat, and her cognitive skills decline. So she's quite able to do a lot of things, but she's not interested. She's in pain. It's just everything's bothering her. So the mother's working very hard at getting her cleaned out and keeping her on a regular bowel regimen by giving her Metamucil, mineral oil, Restoralax, prune juice, and prunes. And she's trying to get her to drink more. She's making a very concerted effort to increase her fluid intake and to maintain a regular exercise routine. They too live on a farm and have farm animals, and she helps out around the barn and so on. So the mother's very good about keeping her active and really staying on top of this regimen and tracking her bowels using a chart to make sure that she's gone every so often, because the goal is to keep her, even if she's having diarrhea at first, that's better than constipation, and then sort of playing around with things until she gets the right schedule in place and the right consistency.
So continuing, and if you notice, what we're essentially doing is going through the health watch, system by system. So now we're moving to the head. And you know this better than I do, but when you suspect headache, when you suspect pain, it's worth to write it on a little chart or on a calendar, just so that you can track and try to find a pattern. Patterns are extremely useful for everybody, and it is sometimes the only way to quickly detect if something is off. This is an MRI and a CT scan of the same patient that has been illustrated in this talk, and at some point she was not herself. She was having not really a lot of fever. She seemed to be not having a regular cold, and they came to a hospital. She seemed to be also having breakthrough seizures, which was very unusual. She had been very well controlled, and on examination, there was nothing extremely obvious to what was found on imaging. Imaging was done because there was, again, not a clear cause for why the discomfort. So we did like a head to toe, and we decided that maybe there was some infection in the ear, and we know that ear infections can progress all the way into intracranial infections. In her particular case, what you're seeing here are the eyes. So this is the left eye, the right eye, and it's like a mirror picture. And this is the brain here, and the white is the bone. And we all have behind the eye air cells called the mastoids, which are supposed to be filled with air. And hers on the right side was clearly filled with air, which is normal. The one on the left had like a big bubble and some material inside that bubble, and there was swelling in the muscles surrounding it. When we obtain a better picture, an MRI, in this case now facing her, so this being the top of her head, this being now the left side, and this now being the right ear, we notice once again that the right ear and the air around the right ear was fine, but the left had a big abscess. Essentially, she had a surgical case of mastoiditis, which is an infection of the ear bone. And all of this white signal here is inflammation. So she definitely was close to breaching into an intracranial infection. Fortunately, the ear, nose, and throat surgeons were able to evacuate the pus, and she received antibiotics. But it's just an example how sometimes a trivial, infection can go the wrong way. And again, not to scare you, because most ear infections will resolve by themselves. Like 70% of ear infections don't even need antibiotics. But the message is that if there's something off, if there's something that doesn't follow the usual pattern as you recover from a cold, then it's good to seek help for that. Eye problems are common. We tend to see children that will excessively rub their eyes, and this can predispose to infections, little small abscesses around the eyelids. There have been some cases of keratoconus, which is where there's abrasion of the retina, so the cornea. So the outer part of the eyeball can be scratched, and then what happens is you cannot tolerate any kind of light because the filter for light is not there. And if it's left untreated, it can become as a permanent scar. There are some studies that have looked at this and found that probably all children will have a minor form of an eye problem that may not require surgery, may not require correction right away, but most frequently the one observed is this one called strabismus with exotropia, which means that the eyes are going to the sides. It can be both eyes, it can be one eye, so kind of like the eye wandering. And this, don't be surprised if sometimes the ophthalmologists don't correct right away. There are times and ways to strengthen the muscles, so sometimes they'll try to patch an eye, sometimes they'll try to use glasses. In some cases they may have to use surgery. Ear, nose, and throat. I already showed you a dramatic example. Most commonly, it is this question of, I almost choked. So I was eating the regular fruits or the little mints that I normally eat. There was nothing unusual, and I start choking. Fortunately, we haven't encountered any fatal cases or anything that had required like urgent interventions from ear, nose, and throat. But the recommendations is to have them looked by an ear, nose, and throat or your trusted health clinic or doctor if you feel there's something that is persistent, if it wasn't one-time incident of gagging. And I think I mentioned the fact that ear infections that go wrong can go into self-injurious behavior, knocking on the ear. In our clinic, so we found that parents tend to check for these things in pre-symptoms, and about 14% of our patients wear glasses, often inconsistently, but they try. And I think finally the dental part. So for all the good reasons, having good hygiene is recommended with early on in life, doing a routine where they learn to feel comfortable with the sensation of the toothbrush, being encouraged to participate in these routines, and maybe providing what is called jewelry. So if there is behavior that makes them prone to chewing on hard surfaces or something that can injure the gums, there are many options for redirecting these chewing habits. In our clinic, we found that most families were pretty good at brushing daily. All of them were at some point meeting with a dentist. There was, however, about 1/3 of tooth or gum problems, and drooling, it was not for 90% of our children, but for at a given time, drooling had been present as excessive chewing and mouthing. And just a word on this, there are therapies that can treat excessive drooling, and they're usually delivered by an ear, nose, and throat specialist. And it can go from Botox injections, which are sometimes not the most practical, but they work. So injecting Botox in the glands can help decrease salivation. There are some surgeries that are not reversible, where they, out of about 4 candidate ducts, they can ligate 1 or 2. They often will leave it as the last resort, because you do need some degree of salivation in order to digest the food you have, etc. There are some medications that can help, but they tend to come with other side effects, or they're not as popular. But there are options. There's some children that have drooled enough that they dehydrate. So if there's like soaking a shirt and soaking a towel, it is something that you may want to look at. From an endocrine and sexuality point of view, so puberty tends to come a little bit late for some females. You may have warning signs other than development of the breast bud, changes in behavior, abdominal pain, like monthly abdominal pain preceding the menstruation, and just to be aware that there have been cases of sexual abuse and sexually transmitted disease, unwanted pregnancies. Some statistical correlation has been found, interestingly, with the use of birth control, but I think that this is something, especially in my mind, when transitioning from a pediatric environment into an adult environment, is something to keep in mind. Masturbation is seen in both sexes, and there's really not a lot more that I can say about that. No damage there. A lot of families they find that dealing with the menstrual period is inconvenient for different reasons. So there are progesterone-based injections that can be applied every 3 months or even less frequently, and that will prevent menstruation. So again, one last word about talking to agencies, about abuse policies, about staff training and supervision. So if there is full-time or shared time in a home group, just you have all the right to inquire if there's awareness about this. And I think this is the end for now for the first part. And we want to thank the Canadian Angelman Syndrome Society and the Angelman Syndrome Foundation, and of course all our families and parents and patients in the Ottawa Clinic in Canada. And now we leave it open for your comments, your questions, and specifically, what else do you find is missing in this health watch table? Anything else that should be emphasized or that is not in the table? Thank you.